Hello, Andrew Colsky with Therapy BTS, Therapy Behind the Scenes, where we talk with therapists and others about what really goes on behind the scenes when you're seeing a therapist. Today, we have Carole Showell, and she is going to be
Hello.
talking with us about some trauma issues. So, Carole, would you introduce yourself to the audience, please?
I am happy to be here and excited to do this. So thanks for inviting me. So again, my name's Carol. I am a trauma therapist. I just did one of the certifications for a what's it called? Certified clinical trauma professional. So like to continue my education and try to stay up to date. I've been in this field. This will be my 10th year working as a therapist and doing trauma pretty much that entire time. Initially, I worked with adolescents for the first year or so, and then transitioned into primarily working with adults with complex trauma. And also, a lot of my clients have borderline personality disorder, which is really just kind of PTSD on steroids. It's like super complex trauma. But I guess we
Oh,
can get into that a little later about kind of what that looks like and a little bit more on that. Um, but yeah, I went to University of Pennsylvania, got my master's in social work there. And I got my bachelor's in psychology from Temple University out here in Philadelphia, where I am based. Right now, I have my own practice where I do some consulting work. And I also see clients through growth therapy. So I have virtual practice, work at home. And prior to this, I worked at an LGBTQ health center. And then before that, I worked at a community clinic. Um, so my work has really all been a lot of community work. That's sort of my passion, what I love to do, clients that I love. Um, so yeah, I'm 40 years old, if you are wondering about my age as well.
well, well, thank you for all that background. So let me make sure I get this right. Do you practice, first off, do you practice only in Philadelphia or across Pennsylvania? Where do
Ac-
you get your clients?
across Pennsylvania and New Jersey. So I'm licensed in Pennsylvania and New Jersey. So that's where my clients are coming from, particularly since I work virtually, really opens that up to people from all over being able to actually come and see me, which is nice instead of only being limited to Philadelphia, because I get a lot of folks from smaller towns and cities who, they can't really find the type of treatment that they're looking for where they live in person. So they're able to connect with me, even though we might be like 3 hours away, which is actually pretty nice.
Yeah, no, I love the fact that we have the ability to do telehealth because you can reach out to people who may not otherwise have had access to the type of
Hmm.
care they need or the specialists that they need. So I'm
Yeah,
glad that you offer that as an option.
yeah.
So, all right, so we've kind of hinted at the fact that you do trauma work. So start us off by telling us, why did Carole decide to go into therapy in the first place, and how
Mhm.
did she end up doing trauma work?
So I decided to go into therapy because my own therapist, who I was seeing at the time, suggested that I would probably be good at that. I was thinking of something I'd been thinking of a little bit for a while. I wasn't really super well versed in the field. This is around, let's say, about 2008, something like that. I've always loved to do a lot of, social justice work, um, anything where I could kind of give back to other people, do some sort of social service. I liked that, but I bounced around from a couple different things, trying to figure out what would fit. Um, and so my therapist at the time, because I myself also have complex PTSD and panic disorder, which I've been treated for, and I currently have my own therapist for those things. And so I thought I had access to some good clinicians, and good family support that I knew other people didn't have access to. So my initial thought was, I wonder if I can help provide that for other people in some way by, going into initially I was going to go into sort of macro social work, which would have been more like policy, that kind of thing. I'm decided, I got halfway through the macro track in grad school before deciding that I really hated it. And then I decided to switch to the clinical track, which I really, really loved. Initially, I wasn't sure I would be good at it. I'm like, oh, I might get overwhelmed. That's too much. But I really connected with the people, that I was working with, and discovered that I loved that. And I could feel kind of provide, well, I guess, fill that gap even better in, working in a clinical capacity compared to it, like the macro tracks. I could really do what I wanted, which was kind of provide things to my clients that I was fortunate enough to have access to that maybe they didn't, that other people wouldn't have access to. So that's how I ended up becoming a therapist. Um, and then, ending up getting additional training and education and still doing that in specific types of uh, treatment modalities for trauma for BPD.
Mm-hmm. Okay. So, so, you shared that you yourself dealt with trauma as one of your own issues.
Mhm.
So, in doing the therapy, not only are you doing therapy that you've learned about, but you also have experienced what your clients have
Yeah.
experienced. And
Yeah, which helps a lot because, and then that's one thing that my clients have actually expressed is that they don't have to necessarily explain everything for me to understand it. And I've had this experience too. What I'm about to say is that sometimes clients will hold back when working with therapists because they're not sure the therapist will understand it, or they're not sure how to communicate it to the therapist, or if there's going to be some commonality. And my clients haven't felt the need, because I do self disclose, obviously appropriately so. When I feel it's going to be useful, just and I think it's even in some of like my bio on like I don't know if it's on my LinkedIn, but I know it's on like my Zen care profile. It's on my group therapy profile, on my Psychology Today profile. I say that I am someone that, struggles and thrives, I think something like that, with mental illnesses of my own, so that they know exactly who they're getting. And that's actually drawn quite a lot of people to me. And that's something that I've done my whole career, is just being very upfront about that with folks. Um, and that's helped a lot. And my own experiences sometimes with therapists in the past, um, there were certain things that I didn't tell them, or I wasn't sure how to tell them, wasn't sure, I didn't have the language, I wasn't sure what the reaction would be, so I would hold back and not say something.
Mhm.
And so I wasn't getting as much out of therapy as I could have because there's certain things that I wasn't comfortable, I was afraid to open up about because I wasn't sure, is this person really going to understand this when I
Right,
talk to them about this?
right.
So one reason I self disclose is to make it really clear that, hey, even if we don't have the exact same experience, I will understand a lot of what you're going to be telling me.
Right. Yeah. No, I'm sure that's very helpful, and I'm sure it's helpful for you to understand them,
Hmm.
what they're explaining.
Yeah, yeah, it is. Um, I know when you and I were sort of preparing before recording this, I was mentioning there are certain things that my clients and I we can say without having to really go into a ton of detail. It's almost like a shared vocabulary, a shared language that um, I can have with them where they can describe something. Maybe they don't have the exact language for it or the like clinical language for it, or they kind of struggle to flesh it out, but I'll know exactly what it is that they're trying to refer to, that they're trying to tell me because I'm like, yep, yep, I know that one. Been there.
Right, right. So, so do you find, as you look across sort of your whole group of clients, do you tend to have more adults, children, teenagers, male, female? What does your client base look like?
So I tend to have Adult females. No particular age range. It's a pretty wide span of age ranges. Um, I should say adult, like cis women and like femme presenting, because I do have a mix, and like trans women as well,
Mhm.
and some non-binary. Um, but I think the largest percentage is going to be adult cis and or trans women. And those are the people I mostly work with right now.
Right.
I do have like a couple of teenagers. I think they're older teens. I try when I'm working with the teens, I try to make sure it's 14 and older, because in Pennsylvania anyway, I'm not sure about New Jersey. I think it's about the same. But the age of consent for mental health treatment is, I believe, is 14. And when I was working with adolescents, most of the work was actually trying to kind of wrangle the families, and you don't just have one client, you might have three instead, because you have the adolescent, and then you have like parents, um and that just gets really really difficult. And so that's something that I'm like, okay, I've done my time with that. 14 or older. So to the client, they can consent to their treatment. It's much easier. They're calling the shots. And so, the type of teenager that seeks out therapy and is ready to make these decisions for themselves, they tend to be like super insightful, very mature, and so it's closer to actually working with an adult, which is a little bit unfortunate, because generally that's because of their life circumstances and what they've been through, that they've had to mature earlier and figure out how to take care of themselves earlier. Um, if you look for a silver lining, though, that means they are able to figure out how to reach out for services and get their needs met. And I can end up working with them almost as if they're adults, because that's just kind of where they are.
Hmm. Wow. So I am curious, and I'll give some background as to why I'm asking this question. So, like for me, um, I treat anybody who has a mental disorder that I work with.
Mhm.
And so I work with different ages. I work with kids, teens, adults. I work with the LGBTQ community, the trans community, anyone if they have a mental health disorder they want help with. And even though I treat anyone who's interested, I find that the majority of my clients tend to be adult males.
Oh, that's
And
interesting.
yeah, so I was going to ask you, you said most of your clients are adult females. And the reason I'm asking the question is because, do you think that it's mostly adult females that have the complex trauma, or do you think that it's just they're coming to you because you're female? Like, who would normally present with complex trauma?
Um, anyone. So anyone. So at least where I am in like the Philadelphia area, um, with the demographics that we have, so it's a majority Black and Brown city. In our community, like Black and Brown communities, there is still, it's getting better, but there is still a stigma about men seeking mental health treatment.
Mhm.
And so just because I'm not seeing them, it doesn't mean it presents more often in women, in my opinion, just because the prevalence of trauma, gun violence, childhood sexual abuse, um, it like certain types of trauma are going to be occur more in certain populations, but there's trauma across the board. Again, though, there is the stigma of seeking out mental health treatment, which I have seen it changing. I have had male clients. I do have some right now. It's just a handful. The people that are most likely to seek treatment, though, uh, in my experience where I am, are going to be women, and like cis women, trans women, non-binary. Um, yeah, that's just how it is right now, unfortunately.
Okay.
Yeah.
Okay. Yeah, I was just curious.
Yeah.
So, we've talked about the word trauma a lot
Mhm.
so far, but why don't we talk about what is trauma? How would somebody know if they're dealing with trauma?
So I define trauma to my clients as the way that I learned it, which is an experience that overwhelms your ability to cope, and it has lasting effects that disrupt negatively disrupt multiple areas of your life for an extended period of time. There are trying to remember what the exact definition. I want to say if it's symptoms that are present for longer than 6 months, something like that. Because when people experience a traumatic, life-changing event, it's a normal response to have maybe hypervigilance for a while, sleep disruption, higher anxiety, feeling unsafe. That can be very normal, but generally, in a natural recovery, which is what we call it, those symptoms decrease and you kind of return to baseline, return kind of to your normal life
Mhm.
within 6 months. If that hasn't happened, at that point, in comes the maybe a PTSD diagnosis, and that's when you're going to need a little extra help to try to resolve those symptoms. So we generally think of um, by we, I mean kind of like a larger society. We think of trauma as like the big T trauma, where it could be a sexual assault, it could be like a veteran from a war, car accident, these big things. But we also have the little T traumas, which is a big part of what I deal with my clients, complex trauma, which are like relational traumas. So these small things where you are like constantly invalidated and gaslit by a parent or a partner, and this happens over a period of like years or a long period of time. Those accumulate. So oftentimes people won't initially recognize those as a type of trauma because it's not like a big T trauma like they're used to seeing on like TV or something like that. Uh, Quite a bit of my work for my clients is helping them recognize that these experiences that they've had are actually traumas and how they're impacting their life. We
Mhm.
can sort of minimize and dismiss them. Oh, my mom screamed at me every day, but like she did that to my siblings and I am fine. And it's like, okay, let's talk about that a little more. Okay, tell me a little bit more about that because that's going to have an impact, even if they don't recognize that it does, it straight away.
Yeah. It's I smile at that one because so many times we're talking to a client and you're asking them about, oh, tell me about your childhood and things. And you typically get the response, oh, it was a normal childhood.
Mhm.
And I smile because it's like, what does that mean? It's the only
Yeah,
childhood that you knew. So to
yeah,
you, that was normal. But then we
yeah,
start digging into it and we start finding out these things, and you find out, maybe this contributes to what we're dealing with here.
yeah, exactly, exactly. Um, I've had plenty of people that are like, oh, it actually had a pretty good childhood. Oh, tell me about your childhood. Then they'll start talking and then find out that, like, I don't know, their parents would just lock them in their room when they got upset and then not talk to them for hours. And that was a regular occurrence. It's just like,
Yeah,
yeah.
it's just really, really interesting to see. So I don't know what a normal childhood really is because
Mhm.
everybody's experience is different.
Yeah. Yeah. So that's how I would define trauma. It's just something that has it's a life-changing impact um that has like a global effect
Hmm.
in
Okay.
multiple across multiple domains. Because normally it's not just one thing that it will affect. It's gonna be like multiple areas of a person's life.
Okay. So a new patient comes in, you
Mhm.
start to find out a little bit about their history. You realize that they do have trauma, maybe
Mhm.
complex trauma. What type of treatments are available to a therapist to help that person?
So I could tell you the ones that I tend to do.
Mhm.
Um, so there is like the ones that I'm certified in are going to be EMDR. No, we can go into more of that a little bit. So EMDR, prolonged exposure therapy. There's also DBT, and there's also CPT, which is a little bit different than CBT. All of these have a lot of CBT in them. um, so I always forget. You think I'd remember it now, but I always forget all of the correct words in EMDR. I'm like, because I just say it by the acronym all the
Right.
time. Hold on. Now I'm like let me Google it really
I'll
quick.
I'll help you
Do
with it. It's
you remember it? Thank you.
eye movement desensitization and reprocessing.
Thank you. I'm like, eye movement back and forth, linky thing. That no, that is not a name, Carol. Um,
So tell us what is EMDR? What would a patient experience if you were doing EMDR with them?
so if I'm doing EMDR with someone, I would start by giving a primer on what it is. So to be clear, we have an idea, we know how it works, but not quite all the details because the brain is a very strange thing. Um, Basically, what it does is it is going to sort of replicate the brain's information processing integration capabilities that in which it's engaging during REM sleep. So that's the part of sleep, the rapid eye movements where your eyes are moving back and forth. You want somebody sleep and their eyes are like back and forth really fast.
Mhm.
Um, that's the part of sleep where we are sort of integrating information from the day and processing it, putting together. I always like visualize it as looking like um, if you've got like a file room and you come in at the end of the day and there's just files all over the place because people are using them. And so you're like trying to put them back in. You're like, oh, this is March 2022. Oh, this one goes, I think it's January 1997. And you're just trying to put them back in order. That's kind of like what is happening during REM sleep in a way.
Okay.
And so with EMDR, we are taking that ability, we're triggering the brain's like capacity to do that by having somebody either track a dot, track a hand back and forth, with bilateral movement. So you can do tones back and forth. You can have them do tapping. Um, with children, you can do this with the dots too, I guess. Even you do scribbling it out, what's it called, scribbling it out with like Foursquare. So that bilateral movement back and forth with your hand it's also counts. You can also tap back and forth on like your thighs or something, which I'm doing now, but you can't see because you can only see me from here up.
Right.
It's basically, I think of it as focusing that that ability of your brain to process and integrate information, and instead of it being dispersed over just all the information from the day, it's focused and concentrated on a very specific negative core belief that is triggered by a very specific event. Um, with EMDR, they used to just kind of have you start with um, the most intense memory, like the worst memory. Now, the way that they train us, at least where I was trained, you can actually break it apart. So you can start with just desensitization, EMD, where you are thinking of like a negative core belief and a recent trigger for that, a recent event that triggered it. You're not processing any memories in the neural network that are related to this core belief. You're just desensitizing, habituating to your reaction to that present event. So you can do that if you're working with a client that maybe needs more help with their emotion regulation skills, with their distress tolerance skills. Maybe they need to build those up a little bit more to be able to process more intense memories. So if you're not ready to go there, you can just have them desensitize and habituate with the bilateral movements or the bilateral stimulation back and forth.
Mhm.
You can also do, I think they changed the names a little bit recently, but it's we learned it as EMDR contained and EMDR restricted. One is where you're bringing in body sensations, but again, it is contained to a very present event. Say something that is like, oh, this happened 2 months ago, or something like that, that triggers a specific negative core belief. Here we are processing more of those thoughts that kind of come up around that. We're still not going too far back in the neural network yet. We're still keeping it very contained, and they're processing that. So with both of these, I forgot to mention this. The first one, you're going to be doing that, and I think about 10-second sets of bilateral stimulation back and forth. And then between each set, you're just kind of asking someone, what do you notice about your thoughts right now? With the EMDR contained or restricted, I'm going to be bringing in, okay, what do you notice in your body right now? What do you notice about your emotions right now? And then you go back into the next set of, in this case, for EMDR contained or restricted, it would be 10 to 15-second sets of bilateral stimulation. And then you can actually, sometimes I go up to 20 for certain people. But then if you're doing regular EMDR, and this is where you're processing the whole neural network. So I keep saying neural network. Think of this as, I use the analogy of a spider web.
Mhm.
So you can poke like one little corner of the spider web and the whole thing will move. So think of each of those spokes in the spider web as a memory and experience. And the further in you go, the further back the memory is. And the bit that winds around and connects them is that negative core belief. They're
Ooh,
all webbed together. So
wow.
that's why you can work with something, an event that's happened in the present with that's triggered the negative core belief, and it's still going to have a ripple effect through that entire neural network, through that entire web. So
Wow.
with EMDR, like just EMDR unrestricted,
Mhm.
now we're bringing in more of those past events that are connected by that negative core belief. The client has a lot of control over how far back they want to go with this. They could say, no, I'm only going back to like when I was like 19 in college right now. So maybe that's where they're ready to go. And we'll go back to that. We have a whole target, what we call a targeting sequence plan that we use that gives us basically a map that tells us what specific memories we're going to be going to, and we just sort of follow that. So we have like the presenting problem, which might be, I have the panic attack whenever somebody gives me feedback or something like that, whenever somebody gives me feedback about my work. And then we've got all of the events in the present and the past that are related to the core belief that comes up whenever you have that panic attack, when somebody or somebody asks you or gives you feedback about your work, which might be, I'm not good enough, or
Mhm.
I'm incompetent. There are a lot of things connected to that negative belief of I'm not good enough or I'm incompetent. And so we pull out specific experiences that stand out for that person in present and past. And those are the ones that we follow. And so again, it's kind of like winding all the way back through that spider web until the center, which is going to be maybe the touchstone. Oftentimes that's like the earliest memory. That's keystone, which is the earliest memory. And then touchstone might be a little bit different, could be the same, but the touchstone is going to be an experience where that negative belief was the most intense for you, the strongest. um I was going to say something, I can't remember what it was, but I think I've kind of explained it pretty well with
Hmm.
what the person can expect. And this is pretty much how I explain it to them when they're coming in, because I like to give people like, here are your options, here's what the treatment can look like, and here's how it goes in a nutshell.
So, I mean, it sounds like there's a lot going on there. So
Mhm.
how long does it take? I mean, does that all happen within a single hour, or how long
No.
does it take?
So we can spend, it really depends on the client. We can spend could be quite a few sessions doing what we call resourcing, which is just building up their emotion regulation, distress tolerance skills. I'm working with one client right now. We haven't started EMDR yet because we're still building up emotion regulation, distress tolerance skills to get there. They have another trauma therapist who's actually doing DBT with them too to kind of help with that. And then I'm coming in to supplement that, but mine is specifically with the focus of starting EMDR. So um, it's a little more focused than what DBT would be, which is its own specific kind of protocol.
Mhm.
Um, so that really depends on the client. When when we're doing a processing session, again, that could take a couple of sessions to process one target, one event. Really depends. I have had one person where it only took one and they're down to zero in their level of distress and up to seven in their what we call validity of cognition, which is how much you believe the adaptive belief. Because that's the second part of this is we're installing an adaptive positive belief and creating a new neural network, sort of
Mhm.
rewriting the spider web, making a new one. Only this time things are connected by that positive belief instead of like the negative belief.
Wow.
Um, so it's very variable, but it speeds up processing by quite a bit when we're talking about trying to work through past traumas. So it's very helpful, and not every session has to be EMDR. Sometimes it's looking back over our target sequence plan and seeing where we are. It's not unusual for us to do some processing and figure out, oh, we don't need to do these other two items on the targeting sequence plan because they've actually been resolved just by processing like this one thing we were working on.
Right.
Um, with clients where I'm their primary therapist or their only therapist, we may be doing like CBT stuff in between or a little bit of like IFS, internal family system stuff, which is another form of treatment that is good for like trauma treatment as well.
Mhm.
That one I'm not like certified in. I do have just like basic training in that. So it's really flexible. It's not something where you have to do it every single week. You can just kind of drop it in as it's appropriate to do it.
Right. Wow. Well, obviously you're very well versed in that technique. I can only imagine the intensity of what a client is going through as they're actually working through all those things.
Mhm.
But so then take me through how would you as a therapist choose between working with EMDR and one of the other things you said you work on is prolonged exposure therapy.
Yeah.
What would that be used for?
So prolonged exposure therapy, that works best if you have a single incident trauma. So if it is something that was one time, very specific. So again, that might be like the car accident, or I got mugged, or something like that.
Hmm.
That also works for clients who are also already very well regulated.
Okay.
So if they're good with distress tolerance, emotion regulation skills, and it's just like maybe they had like a sexual assault or something like that. Um, it's good for that sort of thing, for the single incident traumas, and the person is well regulated. I've used prolonged exposure therapy with clients that starting out were not as well regulated, but there's a lot of groundwork that has in like psychoeducation that has to be done in order to get them ready to do prolonged exposure therapy. So something like an EMDR or a DBT is going to be better for those clients than like prolonged exposure therapy. So that's how I would make that determination. I've used, prolonged exposure therapy with clients fairly recently. And again, it was like well regulated. They were able to handle it in terms of like their emotion regulation, distress tolerance. And also it helps when they have a lot of stability in their lives. So it'll be difficult, or it has in my experience been a little difficult to use prolonged exposure therapy for a client that has a lot of instability in their life.
Mhm.
Whether it's like instability with living, like their living arrangement, social um, system, social interactions, because this is something, it is intense. It's more intense than EMDR. So you're going to need every other area of the client's life to be put together,
Right.
basically, to be very, very stable in order to be able to use it. They're both very effective. It's just different things for different clients.
So in the case where you opt for the prolonged exposure therapy,
Mhm.
in a nutshell, what does that look like? What would a client experience?
So that with prolonged exposure therapy, we would do the trauma interview. This has like a very um, it's a, I think, a more strict protocol. I would say it's a more strict protocol.
Mhm.
So it's the trauma interview, which you have like a forum that we're using for that. When you're used to doing it, it's easy to fill out. You can even kind of skip it because you already know what questions you're looking for and asking. But you're just getting an idea of what specifically they're coming in for, what's happened to them. You're checking to see if there are some past traumas, if those are coming up for them, or if it's just this one primary thing. If they have multiple traumas, you're asking them, okay, what is the one that is like bothering you the most right now? And that's the one that you're going to be working on. So with prolonged exposure therapy, it generally lasts 10 to 12 sessions. You don't want to go over 14 because you kind of get like diminishing returns after that. And it's not really going to be any more effective than it would be at like 12 sessions. So it's 10 to 12 sessions. So unlike EMDR, where it's not really a set number of sessions, this does have a set number of sessions.
Mhm.
Um, you have them write down their trauma narrative, and you are asking them to put down as much detail as possible. So you're trying to pull in all of their sensory information, as much as they can remember. So what did they see, hear, smell, touch, taste? What are their thoughts, their emotions? And then you are going to have them close. There's a couple ways to do this. So you can titrate the experience for them if they're getting overwhelmed, or if you want to ease into it. Generally, you would have them close their eyes. They would, after they've like familiarized themselves with their trauma narrative, they would start at the beginning, and they're giving it from um, like first person. So like I'm walking down the street and I hear a noise behind me. Um, as a therapist, I might interject with, how loud was the noise? It was a loud noise. Did you smell anything? Um, I didn't smell anything. What are you seeing in front of you? So I'm trying to build up the detail of that memory and
Mhm.
put them as close to it as possible without causing a flashback. So you really want to get that proximity. So you can see why you would really need to have very strong regulation skills here for this
Right.
part, because it's asking a lot of the client.
Right.
Um, and so we're building up this memory, as many of these details as possible. And the reason that we do this is they've often gotten used to telling sort of the sanitized version that keeps them emotionally safe, understandable. So it's going to be the one where they have the version where they have some distance from it, where they're not bringing in their emotions as much or their thoughts as much. This may mean that they have gaps in the memory. There are things that they're not recalling. So they have all of these sort of loose ends flapping around. Um, and these are the things that are popping up and causing flashbacks that are causing like PTS triggers, because your brain is trying to process these loose ends that haven't been integrated. They haven't been fit into your life story yet. I'm a very visual, analogy driven person. So I have another analogy for this one. It's a bit like if you walk into a library and the books on the shelves are out of order, and not only are they out of order, but they keep falling off the shelves and hitting you on the head when you least expect it. That's kind of what it's like. And so prolonged exposure therapy is like putting the books back in order and making sure they're all the way on the shelves so they don't fall off the shelf and hit you on the head. And you can make sense of them when you look at them. So it's not like we're getting rid of the memory, but the memory is now organized. It's where it's supposed to be on the shelf. It's not going to fall off and bop you on the head and knock you out when you least expect it. So so they're going through this trauma narrative. I'm titrating this if they're getting if I see that they're getting overwhelmed or overstimulated or dysregulated. There are a couple things you can do. I can either have them open their eyes and like stare at a spot on the floor or spot on the wall and say it. That gives them some distance. I can have them switch to like a third person instead of like first person. So that also gives them some distance from it. Sometimes you can even have the person write it out. That's almost kind of pulling a little bit from resembling cognitive processing therapy where they're writing it out. Generally, most people are able to get through it because, again, it's all about client selection. Using this with the client where it's going to be most appropriate. So hopefully you're not using it with someone that would become dysregulated. Hopefully you've kind of spotted that in advance and like, okay, maybe we need to do some more work, use something different. But they are, repeating this. I usually try to get in 2 to 3 repetitions in one 90-minute session. So the sessions are 90 minutes. An hour will work. It will be effective. It is a little harder to do. You got to be like really, really on your time about that. I'm not keen on doing it in 60 minutes. I do prefer 90, just because you do want to leave room for processing at the end. In this case, processing would be verbal processing, where they have finished the imaginal, which is what we call it when we're doing the repetition. They finished the imaginal. We can talk about their experience. What was that like for you? What did you notice? And this is a really important part because this is where they start putting together their pieces out loud that they've noticed. I didn't even notice that like XYZ, that this happened, or I'd forgotten about this part, or wow, I didn't realize blah, 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 blah. So you can see these loose threads are starting to weave themselves together now. In conjunction with that, you're not just doing the imaginal, but they're also doing work outside of sessions. So we have what's called an in vivo hierarchy, which is just in real life. It's what that means. And these are exposure exercises that they're doing in real life. So while they're habituating and desensitizing through the imaginal exposure, they're also going out and doing things in real life to further habituate and desensitize their the trauma response that they're having. So if, like, for instance, they got into a car accident and it was in front of a this particular grocery store, one thing might be to have them walk by that grocery store or something, because maybe they can't drive by the grocery store now. So you wouldn't have them go straight to driving by the grocery store. You'd want to break it into parts and be like, okay, try like walking by the grocery store. You want the in vivo to last usually about 15 minutes. The idea is just to get the anxiety to peak and then drop, because you're retraining the brain that it can actually withstand the anxiety, and the anxiety is not going to last forever. Because up until now, it's been reinforced where, anxiety, I'm going to avoid. And so that's just reinforcing the anxiety response. So you want to reteach the brain that, okay, I've got tools to manage the anxiety. I'm going to be okay. This isn't going to last forever. It's going to feel uncomfortable. Then it's going to drop. It's going to peak and then drop. And so that's why it needs to last a certain amount of time, generally about 15 minutes. And that's why you don't want to start off with the top thing on their in vivo list and just like flood them. And then that's actually gonna probably cause more problems than it would actually help. And it's a good way to have people drop out of the treatment. So you want to start with something that's going to be like on a scale of 0 to 100, start with something that's like a 40, where it's like
Mhm.
uncomfortable, but they can do it because you want
Right.
them to have some wins, like starting off. Um, and then at the very end, last session, you would have them like this whole time they're doing the imaginal each session. Last session, you'd have them go, or I'm sorry, I missed a spot a bit. Few sessions from the end, they would be doing what we call hot spots. So that's going to be any part of the imaginal where they're still giving you high SUD scores, which is subjective unit of distress. That's their own scale, 0 to 10 or 0 to 100. As they're doing the imaginal, I'm asking them their SUDs every 5 minutes or so, something
Mhm.
like that. Because I want to see if it's dropping or if it's going up or if it's staying the same. So if there are spots in their imaginal where we notice it's still high, we're going to do hot spots, which is they're just um, repeating just that one little bit. So slightly before the hot spot and then slightly after it to try and get that SUD level to go down a little bit further. Um, Ideally, you want the SUD to go down to 0 in like in real life, like practically speaking. That's not always going to happen, especially with the demographics I work with. I mean, if
Mhm.
you're in a dangerous neighborhood, the SUD's probably not going to be all the way down to 0. But if it's down to like pretty low and it's not getting in the way, and you're able to go about your daily life and manage whatever anxiety might still be there, then that's what we go with. So in a perfect world, yeah, you get it to 0. But I mean, if you have it shooting down the block like once a month and it's a genuinely dangerous neighborhood and your trauma is I got shot, like it's
Wow.
just it's not going to go to 0, nor should it, honestly, because you do have to have a little hypervigilance just because of the area that you're in. And that's kind of how they do it with the Army uses prolonged exposure therapy a lot. That's kind of how they do that with them, where their goal is to get them, back into the combat zone. It's not going to go all the way down to 0. That's just not realistic. So they're going to get it as low as they can.
Mhm.
Um, and that's actually where I sort of borrowed that approach from, because when I was trained, we were still trying to get it to 0, and we're like, I don't think you can. And then we did some training, and there are some Army folks there. They were mentioning that that's what they do, is just get it down as low as they can. I'm like, that makes a lot of sense, because given how dangerous a lot of our neighborhoods are in Philadelphia, and a lot of our clients are, having to live in spaces that just aren't safe, not realistic to get it all the way down to 0. But if we can
Right.
get it down to like, oh, it's a 10 out of 100, that's great.
Right.
And so then the very last session, they are going to just do the imaginal once through, including the hot spots, beginning to end, just to really reincorporate everything. And then that's it.
Well, I appreciate that explanation, and I just want to point out for those viewers who have watched some of the other videos where we've talked about OCD treatment and we talk about exposure and response prevention therapy, they'll notice a lot of similarities here, because
Mhm.
prolonged exposure therapy is another version of an exposure therapy
Mhm.
where we're having the patient exposed to the thing that causes them the distress, and they learn to work through it with the help of the therapist. And in OCD, you do the response prevention part, which is typically in OCD, you will have some sort of a compulsion you do. And so you learn not to do the compulsion. But we're talking behind the scenes stuff here. So you start to see exposure therapy concepts can be used in different types of situations and used very effectively. So
Mhm.
I appreciate that explanation.
Yeah.
So one other question for you, because we're starting to run up on time here, but I know you've talked about dialectical behavior therapy, or DBT.
Yeah. Yeah.
Can you give us a sense of what that is and who would you use that for?
Yeah, absolutely. I did just want to say that there is often, you might have noticed this as well, there is often a lot of overlap between clients with complex trauma who also have an OCD diagnosis.
Mhm.
So,
Yep, I
yeah.
definitely agree.
Um, so DBT is dialectical, yeah, dialectical behavioral therapy. That was designed by Marshall Linehan specifically for folks who have borderline personality disorder. You heard me mention earlier that BPD is really just PTSD on steroids. It is complex trauma. A lot, if you look at the diagnostic symptoms of BPD, you'll see a lot of similarity with those of PTSD. It's just heightened. So with DBT, what we're looking for to see if this is going to be a good fit for clients, we look at their emotional reactivity, but not just that. There has to be a combination of like high emotional reactivity, which isn't a negative thing necessarily. It just means that um, you have someone who is more sensitive to negative stimuli. They feel it more strongly, and their emotions are more intense. So part of that is actually biological. I'm someone who has very big emotions, and a lot of that is just that's how we're born. They have done some interesting research studies on babies to see how they react. One of them, I think, was they had babies in like a nursery. I don't remember when this study took place exactly, but they took a feather, I believe it was, and they tickled the baby's noses, and some laughed and some cried.
Hmm.
And so that kind of got them thinking and realized, okay, there is something about how we respond to stimuli that is just hardwired. That doesn't mean that someone is necessarily going to develop BPD, though, just because they have high emotional reactivity. It also has to be combined with a really invalidating environment, with um, a environment where like their emotional needs aren't met, or it's just a poor fit for their emotional needs. So those two things kind of have to be working in tandem for someone to develop BPD. And not everyone in that environment is going to develop BPD. So it's not like a given, like, oh, well, I'm just screwed. I guess that's what it is. And you know, the fact that BPD is really just a lot of complex trauma, is PTSD times 100. That is why it is the one personality disorder that can go into remission completely.
Hmm.
You can recover from it, um, which
Interesting.
actually is kind of an indication that maybe it shouldn't be a personality disorder at all. But that's a whole other conversation about personality disorders. Um, so DBT is really good for that. So when I'm talking to someone and I'm kind of hearing them describe how they experience emotions, they may say something like, people say I'm over dramatic or I overreact. I don't know why this affects me so much. It doesn't seem to bother other people, but I just get so upset. I just have these outbursts. I'm listening for that kind of language. And I'm also listening for how they're describing their interactions with other people, particularly like family members and things like that. So I'll ask them, "Oh, what's your relationship with, your mom, dad, caregiver, siblings, whoever?" I'll be asking, "Oh, what's that relationship like? My mom never understood me. My mom used to yell at me. My mom never believed me. My um, parents wouldn't, they would just leave me crying for hours. Um, they'll tell me to stop getting so upset. It wasn't that bad." So those are the other things. So that's that invalidation piece where they're expressing an emotional need in the only way that they can as a kid, and that's not being attended to or met. And in fact, it's being invalidated and rejected, and they're being gaslit from a very pretty early age. Um, so that's usually what I'm looking for. I will use pieces of DBT for people that don't have borderline personality disorder. I think it's parts of it, or you can just really pull parts of it out if folks are having trouble specifically with relationships, or just with emotion regulation or stress tolerance, or things like that. You can use parts of it for just about everyone. But the
Mhm.
whole course of treatment, if you're using it specifically for complex trauma, BPD, um, you're going to have like the mindfulness component, which is super important. That's the really the foundation, the backbone of DBT is mindfulness, because we have to help people learn to trust their gut and be in tune with their own emotions and validate their own emotions, because they've been told so often that what you're feeling is too much. You shouldn't feel that. How you're feeling isn't right. And so what that does to someone, particularly as an adolescent, when they're just forming their own personality and trying to understand their emotions, that tells them not to trust what they're feeling, that they can't
Mhm.
trust what they're feeling,
Right.
that they are going to have to rely on other people to tell them what they're feeling, because they've been told you you're not a good judge of what you're feeling right now. You're wrong. And so we need the mindfulness component to help them really connect back to their emotions, and their bodily experience of their emotions and their thoughts, and really put those pieces back together for themselves. So you have the mindfulness component. You have the interpersonal effectiveness skills. That's going to be your relationships. Um, so um, how to recognize sort of damaging relationships, how to build positive supportive relationships, how to figure out how to get your needs met effectively in a relationship. Oftentimes we'll have like these emotional outbursts because they learn that's the only thing that will get them attention. That's the only thing that will have somebody attend to them, is if they have a big outburst or if they self-harm.
Mhm.
um, and so this module is teaching other ways, more effective ways that aren't going to harm themselves, that aren't going to harm relationships, that can help them communicate the needs and get those needs met. These are skills that they weren't able to learn earlier in their life, because the first place that we're learning all of these skills is from the people that are around us. If they're not teaching us these things because maybe they don't know how, or they don't have the skills themselves, we're going to have a hard time learning them at those developmental ages. So then we're going to have to try to figure it out as an adult. Um,
Right.
so then we also have like the distress tolerance skills, the emotion regulation skills. So the distress tolerance skills, those are for when your emotions are so intense that emotion regulation skills aren't working. So oftentimes we'll tell somebody, oh, just breathe, just take a deep breath. But if they're at like 7, 8, 9, 10, that breathing is not going to work. They're going to need those distress tolerance skills that change their body chemistry. We need to like sort of trip on that parasympathetic nervous system, which is the rest and digest. We need to activate that to get that cortisol, that adrenaline, to drop down as quickly as possible. Because at that point, when your cortisol and adrenaline, all those hormones that are being pumped out when your emotions are really, really elevated, those
Mhm.
have kind of activated that hindbrain, the fight, flight, freeze, fawn response, meaning the activity in your prefrontal cortex is depressed. It's not as active. And this is where we need to do all of our thinking. So if you're telling somebody, just breathe through it, just think for a second, they can't. They literally can't, because this part of their brain is not as active as it normally would be. It's
Right.
just a survival response. If I have a lion charging out at me, I don't have time to think about, oh, should I run? Maybe I'll run to the left. Should I run? Like, I guess I can go this speed. No, we need to just act. And so that's what the brain is doing. So the distress tolerance skills are designed to um, kind of turn down all of that. And so
Right.
that then we can like think through it and bring in those emotion regulation skills that are going to work. So
Wow. Wow, there's a lot there. Obviously, you've done a
yeah.
lot of work to get to where you are, and we can see that. So, we've run up against time here, but I really, really appreciate you taking the time to go through all of this and share your
Yeah.
experiences. And give people a really good understanding behind the scenes here of what's going on with your therapist when they're working with you with trauma and complex trauma situations.
Yeah, my pleasure. I love talking about this stuff. Can you tell?
Well, tell us this. If somebody is watching this podcast and they're in Pennsylvania or New Jersey and they
Mhm,
want to get in contact with you to
mhm.
talk to you about treatment, how would they find you?
So they can find me on Growth Therapy or zencare.co. Right now I'm full. I should be having some spots opening up probably in a month or two though.
Mhm.
But you can always contact me. I can add you to a wait list. Um, yeah, because my schedule can be a little bit flexible sometimes as people, if they get further in their treatment and then, they might only come in once a month, that's going to open up some slots week to week. So
Right.
just because if it says not accepting decline or says wait list, reach out to me anyway. Yeah, you can find me Growth Therapy or zencare.co.
Fantastic. Well, again, thank you so much, Carole, for taking your time to share all this knowledge with the
Sure.
audience. And maybe we can have you back in the future to talk about some more things that you're working on.
Yeah, I would love that.
All right. Well, we appreciate it, and I look forward to talking with you again further.
Thank you.